Okay, so next question. All are seen in the keratoconus except progressive vision loss. Progressive vision loss due to increasing myopia and irregular astigmatism. Kessler Fleischer ring, scissoring reflex in retinoscopy, and Munson sign positive. And the answer will be Kessler Fleischer ring. So Fleischer ring is seen in keratoconus. Only Fleischer ring. Note it down. Fleischer ring is seen in keratoconus and not Kessler Fleischer ring. This KF ring or Kessler Fleischer ring or KF scene is seen in Wilson's disease. But only Fleischer ring is seen in keratoconus. So in keratoconus, progressive vision loss due to increasing myopia and irregular astigmatism is present. Scissoring reflex in retinoscopy, it is present. Munson sign positive, it is also present, but not KF ring. Instead, only Fleischer ring is present in keratoconus. Now, keratoconus, what is keratoconus? It's a conical cornea. It's a non-inflammatory bilateral condition, ectatic condition of cornea in its axial part. The patient presents with defective vision due to progressive myopia and irregular astigmatism. So, some of the important features coming, important features of keratoconus is progressive myopia. Number two, irregular astigmatism. Now, these features should be very clear to understand the case studies. Case studies are very common from ophthalmology, and sometimes not big, maybe 2 to 3 line case studies can come. So the features should be very clear, or else everything will jumbled up. All the conditions will jumbled up, and quite advanced type of questions come. Sometimes normal question like very simple question, anatomical question, those extraocular muscle questions can come from that portion also, those portion also, and also from these conditions. Clinical questions are fully hard, not hard, I mean the complete clinical questions can come like this. In fact, they will ask for diagnosis and treatment. They will give the features. So features must be known to you. Okay, so progressive myopia, irregular astigmatism which does not improve fully despite correction of glasses. This is important. This portion, these small things are also important. It does not improve even with glasses. Astigmatism. Next, slit lamp examination is done. And we get thinning and ectasia of central cornea, opacity at the apex and Fleischer rings at the base of the cone, folds in Deschamets membrane and Bowman's membrane. So slit lamp examination, thinning of cornea, opacity at the apex, Fleischer ring at base of the cone. So folds in decimate and Bowman's membrane. Next, folds in decimate and Bowman's membrane. So these are the features, slit lamp features, slit lamp examination features. Like thinning of cornea, opacity at the apex, Fleischer ring at the base of the cone, and folds in decimate and Bowman's membrane. Next is Vogt's line. Vogt's lines, very fine vertical deep stromal stria or lines which disappear with external pressure on the globe, are the peculiar features. So Vogt's lines are features seen in keratoconus. On the retinoscopy, a yawning reflex or scissor reflex is found. And Munson sign, what is Munson sign? Munson localized bulging of the lower lid when patient looks down is positive in the later stage of keratoconus. Okay, so this is the Fleischer ring, and this is Kf ring in Wilson's disease. Wilson's disease, you see the deposition. Deposition occurred, but Fleischer ring visible or visible all around the base of the cone in keratoconus. Corneal becomes bulged out. It should be, this is normal. This is normal. Like this. This bulging out of the cornea will be much prominent. Will be much conus, like prominency will be there. This bulging out will be prominent. This is keratoconus. Okay, so let's find out. Let's see the pathogenesis and clinical findings. First of all, the as a another thing is for IBQ, Fleischer ring is very important. Fleischer ring is hardly very difficult to see. This is the ring. If you can appreciate. mm, this is very thin line is seen. This is Fleischer ring. This is Fleischer ring, and KF ring is quite visible. Its deposition and deposition is quite visible. Okay. So in keratoconus, what happens? Firstly, as part of the etiology, we can see the genetics. As part of the genetics, you see family history of keratoconus. Family history is very important. EDS, Ehlers-Danlos syndrome, Down syndrome, Turner syndrome, Marfan syndrome, osteogenesis imperfecta, Leber's congenital amaurosis, vernal keratoconjunctivitis, retinitis pigmentosa. These are all genetics. These are all genetic causes of keratoconus. Next, biochemical factors includes proteolytic enzyme, increase of proteolytic enzyme, decrease of protease inhibitors, increase of pro-inflammatory markers, decrease of anti-inflammatory markers, decrease of stromal keratocytes, changes in collagen types 13, 15, 18. Biochemical factors, contact lens use, eye rubbing, atopic diseases, UV radiation. Biochemical factors, these are biochemical factors due to which keratoconus development of keratoconus is contributed. Okay. So next, you see bilateral asymmetric corneal thinning occurs. Bilateral asymmetric corneal thinning. When corneal thinning occurs, there will be degeneration and cone-shaped protrusion. So you can understand one thing, that corneal thinning occurs. Corneal thinning, and due to that there will be protrusion. There will be protrusion, to be specific, very localized protrusion. Very localized protrusion. Now in keratoconus, what happens? Corneal thinning and cone protrusion, irregular myopic astigmatism. Now the problem is, if cornea bulges out locally, okay, bulges out, what will happen? There will be the refraction of the light. The refraction of the light will be abnormal, abnormally refracted, and obviously it will be not going to the retina very clearly, and there will be myopia. That means it will be more cone bulging. That means more convergence. Curvature increase. That curvature myopia. Okay, curvature increase, more myopia, more convergence, more convergence, and more convergence leads to myopia. We can say myopia, or the two light beams, extremes of the light beams will converge before retina, before falling into retina, and there will be irregular myopic astigmatism as well. Astigmatism, not only myopia, myopic astigmatism will be there. Worsening, and it will worsen the overall visual acuity. Now keratoconus changes in decimate membrane occurs. Decimate membrane, there will be vertical striae. Okay, so decimate membrane, there will be vertical striae. Vertical striae means vertical lines, and hydrops. Hydrops mean accumulation of fluid. Now these vertical lines will be produced by the compression of the decimate membranes, while this accumulation of fluid, it breaks into decimate membranes, breaks in decimate membrane and cause acute stromal edema. Acute stromal edema. And this compression of decimate membrane will lead to disappearance upon application of physical pressure, leading to Vogt striae. And these hydrops will cause stromal edema, then sudden vision loss will occur and pain with severe keratoconjunctivitis. It means redness and all, with keratoconjunctivitis, and will lead to stromal scarring. Stromal scarring. Next, due to this myopic astigmatism, what happens? Hemosiderin deposition occurs. Iron from the tear film deposits into the cornea and the site of abnormal curvature and lead to Fleischer ring. So basically, this Fleischer ring is caused by iron deposition. And this cave ring is caused by actually copper deposition. In Wilson's disease. Okay. Next, another thing is that myopic astigmatism in V-shaped lower eyelid, which is deformed by the cornea when eye is in downward position. Okay, so V-shaped lower eyelid, due to the pressure of this bulging, it will become V-shaped, and this lower eyelid is deformed, becomes deformed by the cornea, by the bulging cornea, when the eye, specifically when the eye is positioned downward, and this leads to Munson sign. Munson sign is localized bulging of the lower lid when the patient looks downward. Next, bright reflection. This is Munson sign. Here, lower eyelid is bulging. Next, bright reflection of the nasal limbus when the light is directed onto the temporal limbal area, and that is called Rigitis sign. Then spontaneous breaks in Bowman's membrane occur due to thinning, and there will be corneal scarring. So there will be stromal scarring also, there will be corneal scarring also, leading to corneal opacities and vision loss. So it should be very, very clear what are the things, what are the pathological changes occurring in keratoconus in details, because there will be questions like some of the questions I can discuss, like Fleischer rings in keratoconus is due to deformed cornea, due to thinning of the Bowman's membrane, compression of the decimate membrane, iron deposition. Now you see, iron deposition, this option looks like very, very odd out. I mean odd or not, like these are all deformed cornea, Bowman's membrane thinning, decimate membrane compression, but it can come into your mind that why suddenly there will be iron deposition. So you may not go towards iron deposition, and that is why that may confuse you. Overall, you must know, because at the time of examination it will be very difficult for analysis. So if you know there is hemosiderin deposition, then you can understand the why Fleischer ring occurs. Now, what is Munson sign? Very important, Munson sign. Because from the name of the sign, there is no way you can understand what is why it is happening. Like what is Munson sign? From the name, you cannot, you can never understand. And questions do come, not like what is Munson sign, but Munson sign is, or Munson sign in keratoconus characterized by like this. So the signs, what are the rings? All main pathological mechanisms, all these sign and symptoms should must be known. Okay, and keratoconus is very important topic. Okay, next question. Recurrent corneal erosions are seen in corneal dystrophy, keratoconus, keratoglobus, corneal degeneration. And the answer will be corneal dystrophy. Corneal dystrophies. They are inherited disorders in which the cells have some inborn defect, due to which pathological changes may occur with time, leading to hazy cornea. Leading to hazy cornea. So basically, in the corneal dystrophy, there will be hazy cornea. There will be hazy cornea. Corneal dystrophies are classified according to the anatomical site involved. Anterior dystrophy, stromal dystrophy, posterior dystrophy. In anterior dystrophy, among anterior dystrophies, epithelial basement membrane dystrophy, also known as Cogan's microcystic dystrophy, is the most common. These lesions involve corneal epithelium and presence as bilateral dot-like microcystic or linear fingerprint opacities. In 10% of cases, there is recurrent corneal erosions, and majority of cases remains asymptomatic. It is characterized by the failure of the failure of the failure of the most outermost failure of the corneal outermost layer of epithelial cells to attach to the underlying basement membrane, that is to with Bowman's layer. And the condition is excruciatingly painful because the loss of these cells results in exposure of sensitive corneal nerves. And the causes include there is often a history of previous corneal injury. Often a history of previous corneal injury, corneal abrasion or ulcer. It may also due to the corneal dystrophy or corneal disease. And treatment will be patching with plain ointment for 1 to 2 days. Another thing, very important, this IBQ, image based questions, this picture, how it looks like. You see the opacities. Opacities are very typical for corneal dystrophy. Next question, very important question. A patient of 16 years old presented with diarrhea, dermatitis, vertigo. Her eye presents a blackened lesion, and the blackened lesion is here. Most likely diagnosis corneal dystrophy, HSB, herpes simplex virus infection, vitamin A deficiency, vitreous hemorrhage, and the answer will be vitamin A deficiency. So the most common ocular manifestation of vitamin A deficiency is xerophthalmia. This condition includes milder stages of night blindness and conjunctival xerosis, dryness with bitote spot. So these spots, these we can see, these are all bitote spot. These are all bitote spots and its variants. All these are bite spots. So features of vitamin A deficiency, there will be diarrhea, there will be dysentery, measles, malaria, respiratory symptoms. This can pose risk to life if associated with vitamin A deficiency. So anyway, vitamin A deficiency is characterized by diarrhea, dysentery, measles, malaria, respiratory symptoms. And acute vitamin A toxicity leads to increased ICP, leading to bulging fontanelles, vertigo, diplopia, seizure, exfoliative dermatitis. And in chronic cases, there will be dry skin, chyliosis, glossitis, alopecia, bone demineralization, hyperlipidemia, hypercalcemia, amenorrhea, features of pseudotumor cerebri with increased ICP and papilledema. Okay, so always remember this bite or spot. These spots must be remembered. Next, giant dendritic ulceration on cornea is seen in the case of fungal infection, chlamydial infection, herpes simplex infection, herpes simplex virus infection, and pneumococcal infection. So giant dendritic ulceration on cornea is seen in case of fungal infection, chlamydial, HSV, and pneumococcal infection. The answer will be HSV infection, herpes simplex virus. Very important. So giant dendritic ulceration on cornea is found in HSV infection. Viral keratitis causes corneal ulceration. Viral keratitis causes corneal ulceration, which is most commonly by herpes simplex, zoster adeno viruses. Dendritic geographical corneal ulcers are seen in herpes simplex ocular disease, while dendritic ulcer, branching ulcer with knobbed ends, resembles no other condition and is pathognomic of herpes simplex ocular infection. So dendritic geographical corneal ulcer is seen in herpes simplex ocular disease, while dendritic ulcer is very much pathognomic, okay, pathognomic of herpes simplex. And the use of steroids in dendritic ulcer hasten or the quicken the formation of geographical ulcer, so it is contraindicated. So we do not use steroids in dendritic ulcer. We do not use steroids in dendritic ulcer. Okay, next. Which one of the following is a drug? Which one of the following drug is contraindicated in the treatment of the dendritic corneal ulcer? Which one of the following drug is contraindicated is contraindicated in the treatment of dendritic corneal ulcer. Okay. Atropine, cefazolin, acyclovir, dexamethasone. So just now what we studied, use of steroids in dendritic ulcer hasten the formation of geographical ulcer. That is why steroid in dendritic ulcer, steroids in dendritic ulcer is contraindicated. Contraindicated. So the answer will be dexamethasone. Dendritic ulcer is an irregular branching ulcer. As you can see, this is a typical dendritic ulcer and is very, very important, very important for FMG. Very important for FMG. Already questions IBQ. This image has come like this. Image has also come like this in within these 2 to 3 years, and it's quite asked. This image. Dendritic ulcer is an irregular branching ulcer with knobbed ends and reduced corneal sensation seen in epithelial keratitis caused by herpes simplex infection. Steroid cause progression of the dendritic ulcer into geographical ulcer, so they are contraindicated, and the treatment is done with 3% acyclovir ointment, 3% acyclovir ointments and mechanical debridements, and other antibiotics may be required if there is secondary infection. Herpes simplex virus infection with the disc-shaped ulceration is seen in epithelial keratitis, stromal keratitis, cephalitic keratitis, and interstitial keratitis. And the answer will be stromal keratitis. Stromal keratitis manifests as keratitis disc-shaped ulcer with surrounding Wesley immune ring. Surrounding Wesley immune ring formed due to delayed hypersensitivity to herpes simplex virus antigen, or diffuse stromal necrotic keratitis due to active viral invasion and tissue destructions. So, stromal keratitis manifests as keratitis or diffuse stromal necrotic keratitis, where disc-shaped ulcer with a surrounding ring, and that the name of the ring is Wesley immune ring, is formed due to delayed hypersensitivity reaction to which antigen? To herpes simplex virus antigen. To herpes simplex virus antigen. And the treatment is steroid drops with acyclovir 3%. Steroid drops with acyclovir 3%. In which cases we do not use steroids? In cases of dendritic ulcer. Dendritic ulcer, if there is dendritic ulcer, this is the dendritic ulcer. If there is dendritic ulcer in herpes simplex infection, then we do not use steroids. Why? Because dendritic ulcer will hasten the formation of geographical ulcer. Dendritic ulcer will form the geographical ulcer, and so it is contraindicated. Okay. Dendritic ulcer. This dendritic ulcer, upon use of steroids like dexamethasone, will form dendritic geographical corneal ulcer. That is why we do not use steroids or like dexamethasone. Okay, in stromal keratitis, we use steroids drops with steroid eye drops with acyclovir 3% acyclovir. Next, epithelial keratitis. It is caused by herpes simplex virus again. Manifest as dendritic ulcer. Irregular manifest as dendritic ulcer. Irregular linear branching ulcer with knob dents, reduced corneal sensation or geographical ulcer, large amoeboid ulcers. Geographical ulcers are large amoeboid ulcers. Steroid cause progression of dendritic ulcer into geographical ulcer, and that is why we do not use steroids if there is dendritic ulcer. If there is dendritic ulcer, okay. And only 3% acyclovir ointments can be used. Acyclovir antiviral, not steroid. Antiviral ointments can be used. But in stromal keratitis, you see acyclovir is also used, and with steroid drops. Means steroid drops with acyclovir. Steroid drops is used. Okay, next. Interstitial keratitis is found in trachoma, bacterial conjunctivitis, fungal conjunctivitis, syphilitis. Interstitial keratitis is found in syphilitis. Syphilitic keratitis actually. So keratitis simply means corneal inflammation. Interstitial keratitis is found in interstitial keratitis basically means what? Corneal scarring due to chronic inflammation of the corneal stroma. So interstitial keratitis means corneal scarring. And this occurs due to chronic inflammation of corneal stroma. Chronic inflammation of corneal stroma. Okay. Interstitial means space between cells. That is corneal stroma, which lies between epithelium and endothelium. And is most commonly seen in infection like syphilis. Most commonly seen in infection like syphilis. Now, syphilitic keratitis. It is seen more. It is seen more frequently with congenital syphilis than acquired one. So in congenital case, it is seen more than acquired. It may present as a part of Hutchinson triad. Hutchinson's triad is interstitial keratitis, Hutchinson's teeth, and vestibular deafness. Hutchinson's teeth is like this incisor. Typical shape of the incisor will be like this. Hutchinson's teeth. Next question, which of the following is used in acanthamoeba keratitis? Acanthamoebic keratitis. Which of the following used in acanthamoebic keratitis treatment? Okay. Topical corticosteroids, propamidine, isothiionate, acetazolamide, and artificial tear. And the question answer will be propamidine, isothiionate. So acanthamoeba keratitis. Acanthamoeba keratitis is a free acanthamoeba. First of all, is a free-lying amoeba found in soil, fresh water, well water, sea water, sewage, and air. Mode of infection is direct corneal contact with any material or water that is contaminated with the organism. Direct corneal contact, like we use fresh water or well water or sea water, fresh water or well water to maybe to clean the face, to clean face, or to use water to freshen up to clean the eyes, especially in the village areas. That is done. So what happens is that if acanthamoeba is present, there can be acanthamoebic keratitis. Direct corneal contact. Contact lens wearers using homes also, they emit saline from contaminated tap water, which is the commonest situation recognized for acanthamoeba infection. Other situation may be mild trauma associated with vegetables, saltwater diving inside the sea, wind blown contaminant, or hot tub use. And as an opportunistic infection also it can occur. Now the symptoms: very severe pain. The first thing is very severe pain, out of proportion to the degree of inflammation, watering, photophobia, blepharospasm, and blurred vision. Treatment will be propamidine isothiionate, brolin drops, neomycin drops, polyhexamethylene biguanide, or chlorhexidine. So these are the treatments. Okay, especially we need to remember 0.1% propamidine isothiionate drops. That is the most important treatment. Giant papillary conjunctivitis. Now next, giant papillary conjunctivitis is caused by contact lens wearing, ocular prosthesis, protruding corneal sutures, and all of the above. So giant papillary conjunctivitis is the inflammation of conjunctiva with the formation of very large size papilla. It is a localized allergic response to a physically rough or deposited surface. Okay, it is localized allergic response. Giant papillary conjunctivitis is localized allergic response to a physically rough or deposited surface. And the symptoms includes itching, stringy discharge, reduced wearing time of the contact lens or prosthetic shell. Treatment is offending cause should be removed, and disodium chromoglycate is known to relieve the symptoms and enhance the rate of resolution. Disodium chromoglycate. Okay. Long-term use of contact lens may complicate due to Aspergillus, acanthamoeba, pneumococcus, pseudomonas. Pseudomonas will be the answer. It is the commonest organism or most common organism affecting the long-term use of contact lens. Must be remembered, very important question. Contact lens, everything is about contact lens is very important. Contact lens, most common organism affecting contact lens wearers for chronic or long-term period. For long-term, and is followed by, first is pseudomonas, and is followed by acanthamoeba. Signs suggesting the former infection: presence of ring-shaped ulcer, lack of vascularization, pain out of proportion, pseudo dendritic. Dendritis. Pneumococcus, the commonest cause of the corneal ulcer in India is Streptococcus pneumoniae. Most common cause of corneal ulcer in India. Very, very important. Most common cause of corneal ulcer in India is Streptococcus pneumonia. Causes central corneal ulcer. Whereas the commonest cause in the world is Staphylococcus aureus, causes peripheral one, peripheral type. The bacterial ulcer can present with the formation of hypopyon. And the characteristic hypopyon corneal ulcer is due to pneumococcus and is called ulcer serpens. Very important term. Important term. Ulcer, ulcer serpens. It looks like snakes, those ulcers. That's why ulcer serpens. And treatment is gentamicin, number 1, tobramycin, and treatment can also be topical gentamicin, cefazolin with sacroplegics. Sacroplegics like atropine ointments and analgesic for pain, for relieving pain. Okay. Okay. Anyway, this is about today, and in the next class we will continue with this, because as per our schedule, you can see ophthalmology is for 2 days. Okay. Okay, thank you for today.